Hello everyone, welcome to your very final lecture for the course Pathophysiology. Today we're covering shock and burns. We will go into quite a bit of detail, or at least spend most of the lecture on the different types of shock that exist. Then we'll talk about multi-organ dysfunction syndrome and burns. There are 5 different types of shock that we're going to talk about today, and it's going to be important for you to learn the major differences between the different types of shock. But the first question is, what is shock, generally speaking, and what are the common denominators? Shock is a multi-system failure. It's going to affect many organs and systems in the body at the same time. The circulation fails, or the microcirculation. So this is what, when we're talking about the microcirculation, we're referring to when we get down to the level of the tissues, where we have arterioles and we have capillaries. And we know that it's the capillaries, at the level of the capillaries, where perfusion to the tissues occur. So this is a very vital component that needs to be functioning properly. Otherwise, tissues will be starved of what they need to survive. Shock can trigger this cascade of events that further damage the body through a positive feedback loop. Remember that a positive feedback loop is going to be one that accelerates events rather than halts them, as we would see with negative feedback loops. This makes things worse and worse and worse. One event leads to another event, which leads to another event. These are negative events when we're talking about shock, of course, and it leads to this downward physiological spiral. When shock is identified, it's important to figure out what stage a person is at, and it's going to be necessary to really try to prevent this downward physiological spiral that will likely result in multi-organ failure, which will then result in death if it's not controlled. So what happens inside the cells themselves? You've seen this slide before back in Patho 1, and on the left of your screen you can see a normal cell, and on the right the effects that occur when shock happens. And so even though this slide is showing you the major cellular events that can occur during shock, remember that with shock this is happening in every cell everywhere in the body. So some of the events to point out, there is cellular edema that's going to be caused by alteration in transport of sodium and water due to lack of ATP. Remember the importance of having oxygen available for ATP production. There's going to be increased membrane permeability, rupture of lysosomes, and what that will do is, because lysosomes contain very powerful digestive enzymes, these enzymes can be released intracellularly and have very damaging effects. There's mitochondrial damage that's evident, and the efflux of potassium, and this relates to a problem with normal permeability, and this can lead to hyperkalemia, or high levels of potassium in the blood, and I'll remind you a little bit later about what effect that can have on other organs of the body. So here's a very busy image, but you only need to be aware of what's outlined in red, and it is pretty straightforward, with much of it being a reminder of what we've learned about already in previous lectures. With shock, recall that the problem with the microcirculation is going to lead to this reduction in tissue perfusion all throughout the body. So blood is not arriving at the tissues. A major problem is going to be impaired oxygen delivery and use of oxygen, and this leads to hypoxic injury. But again, this is happening in every cell in the body. So the body cells end up running on anaerobic metabolism, which will ultimately reduce the amount of ATP in the body. Remember again that oxygen is required to make the majority of ATP in the body, that stored energy that we need for all of our body functions. When the body runs on anaerobic metabolism, lactate will be produced. So think back to normal anatomy and physiology when discussing glycolysis and fermentation and that production of lactic acid. So this increase in lactic acid will lead to metabolic acidosis. This acidotic state will further contribute to events by reducing oxygen affinity for hemoglobin, meaning that there's a further reduction in the amount of oxygen that ends up reaching the cells in the body, leading to such events such as cellular edema, which we can see down here. Because remember that oxygen is required for normal cellular metabolic processes. The next point to make is the fact that there will be impaired glucose delivery and use. When shock happens, the body goes into general adaptation syndrome, which you might remember from our stress lecture. So it goes into stress mode. Glucose will increase in the blood, more specifically in the serum, because of cortisol. There'll be an increase in catecholamines as part of a sympathetic response. Remember, examples of catecholamines are epinephrine and norepinephrine that you'll recall that they're about their relationship to the stress response. There'll be an increase in the breakdown of glycogen into glucose, glycogenolysis, putting more glucose in the blood, which ultimately reduces energy stores. There'll be the formation of new glucose, gluconeogenesis. The body really reacts to this situation, this very stressful situation, by trying to get energy from everywhere in the body in response to the stress, including the breakdown of fat in order to increase the amount of energy that's available. And so all energy that's possible is mobilized in this very stressful event, which ultimately depletes stores. So now that you're aware of some of the basic common denominators of shock, let's go into the different types of shock that exist. And we'll start with hypovolemic shock. Hypo, we know, means low. Volemic has to do with the intravascular volume. So we could say low intravascular volume. Hypovolemic shock is caused by insufficient intravascular fluid volume, which the name itself suggests. And the most common causes are hemorrhaging as well as burns. So really, anytime there's loss of blood within the vessels for whatever reason, which you can see with both hemorrhaging and burns, then it can lead to hypovolemic shock. But what's interesting is that this hypovolemic shock can be triggered with volume loss as little as 15%. So in other words, it can happen very easily. So this slide shows how the body responds to states of hypovolemia. And there are two types of compensatory mechanisms that exist in order to try and control for this state. So the example here is they're showing what looks like a minor bleed, but we're assuming that at least 15% of that volume is lost. The first compensatory mechanism is in order to try and maintain cardiovascular function, and this is a sympathetic response. So increased heart rate and increased contractility will occur. So the heart has to pump harder, but when the heart pumps harder, it now is going to require even more oxygen, which becomes a problem considering this hypovolemic state. And so this can lead to eventual failure. Another compensatory mechanism seen relating to maintaining cardiovascular function involves the blood vessels. They also respond by vasoconstricting in areas where organs are considered to be non-vital or less vital, and this includes the skin. So vasoconstriction occurs in the skin, and this will help divert blood to the organs that are necessary for survival. Now, if this is short term, a few minutes or so, then maybe not a problem to the organs that are not getting the normal amount of blood flow. But if it lasts too long, then it can lead to injury and even death to the tissues that are suffering from this ischemia due to the compensatory mechanism. So for example, the skin could start to die because of the lack of blood flow if it lasts too long. The second compensatory mechanism involves mechanisms in order to maintain or designed to try and maintain blood volume after blood loss. Remember that whole blood is made up of formed elements, which are the red blood cells, platelets, and white blood cells, and plasma, which is primarily water. And so an increase in water in the vessels will increase blood volume. Now, ADH, or antidiuretic hormone, this will be released from the posterior pituitary gland. which will have an effect on the kidney in order to retain water. So remember that, for example, coffee is a diuretic. A diuretic makes you pee, allows for the increased production of urine. Therefore, you lose water. So anti-diuretic hormone then does the opposite, and it promotes the reabsorption of water in order to increase your blood volume, because if we increase the amount of water that is reabsorbed from the kidneys and it's put into our blood, it's added to the plasma, which we know is primarily water, which will overall increase blood volume. Also involved is the renin-angiotensin-aldosterone system. This will be activated, that will ultimately allow for aldosterone to stimulate the kidneys to reabsorb sodium. And when sodium is reabsorbed, due to the rule of osmosis, we know that water will naturally follow. Both of these events then are going to be working to increase blood volume. Angiotensin, this is a hormone that has an effect where it promotes vasoconstriction, so ultimately increasing blood pressure. So a vasoconstriction effect. In addition to its promotion of sodium retention by the kidneys due to aldosterone. Now at the level of the liver, there will be constriction of veins and sinusoids with the mobilization of blood that's stored in the liver. In other words, the liver will expel some of its stored blood, because it does act as a bit of a reservoir of blood, in order to increase blood volume for the sake of saving other organs. When there is loss of volume within the vessels, there will be a reduction in tissue perfusion. Remember that there's a relationship between blood volume and blood pressure. So reduced blood volume then will lead to reduced blood pressure. There will be a reduction in capillary hydrostatic pressure, which you might recall is the pressure of blood against the vessel wall, and it needs to be high enough at the level of the tissue in order to allow for blood to leave the vessel and perfuse the tissue. We spoke about how arterial vasoconstriction will occur in states of shock in order to divert blood from the less necessary or organs that are considered not to be vital in order to supply those that are vital. And I mentioned earlier that if this lasts only a few minutes, not necessarily a problem, but if it lasts longer than that, an hour, then hypoxia will start to occur in those cells that aren't getting their normal amount of blood supply, and this will lead to ischemic injury. And it can be reversible initially if the problem is corrected within a relatively short period of time. Otherwise, it will lead to irreversible ischemic injury to the cells that are involved. On the right of your screen, you can see a couple of different nephrons, the functional units of the kidney. And you might recall that blood will enter the kidney through the renal artery, and then it will end up entering into the renal corpuscle through the afferent arteriole. And blood enters through the afferent arteriole. We know that this is where initial glomerular filtration occurs, and then the filtrate moves through the tubular system. And throughout this movement, our body, the kidney, all of this vascular supply will take back what we need. It might add some more to the filtrate depending on what our body needs at the time. And then whatever ends up in the main distal part of the collecting duct will become urine. And so if there's vasoconstriction, arterial vasoconstriction that's happening at the level of the kidney, this can lead to hypoxia of the tubular system. And if there's hypoxia of the tubular system, then the tubules are not able to concentrate urine properly. So under this hypoxic state, these affected individuals will suffer from polyuria. In other words, they'll produce a lot of urine. And they'll produce a lot of urine, once again, because the tubular system in their hypoxic state is unable to properly concentrate the urine. So it produces a very low density urine and a lot of it. And eventually, if the kidney is under a hypoxic state for a period of time, that exceeds the body's compensatory mechanisms, it's not corrected, then necrosis can occur of the kidney, and then this is when the diuresis will stop, or that polyuria will stop, because the kidneys themselves have failed. The next type of shock we will briefly look at is called cardiogenic shock. This was relevant when we spoke about left heart failure earlier in the term. It is an acute physiological condition caused by the inability of the heart to pump sufficient blood for the needs of the body. Now, much of what's written on this slide will be familiar to you from when we spoke about heart failure, but just a little bit as it pertains to cardiogenic shock. When the left heart fails, it's going to be very obvious that there's going to be low cardiac output, and so the tissues are not going to be getting the blood supply that they need for survival. But these compensatory mechanisms are going to kick in that ask so much of the heart in trying to pick up the cardiac output. And when the myocardial cells need more oxygen because of the increased demand, this is just naturally going to make things even worse than they already were. The heart was already failing to begin with, then there's more demand on the heart, needs more oxygen, everything starts to spiral out of control. So the entire body will end up not getting the blood supply that it needs for survival, including the heart itself. The next type of shock we'll briefly look at is neurogenic shock. Neurogenic shock is shock that's caused by alterations of the central nervous system, mostly due to an imbalance in the autonomic nervous system. So remember, the autonomic nervous system, you have the two divisions, being the sympathetic nervous system and the parasympathetic nervous system, which have very opposite effects, but they must be kept in balance for homeostasis. And what this leads to, this imbalance, is this massive vasodilation that occurs. And this is really the primary component of this type of shock. This massive vasodilation corresponds with a reduction in vascular tone and then ultimately a reduction in tissue perfusion, but it's purely a neurological cause. So if somebody suffers from a brainstem injury or a spinal cord injury, then they could possibly suffer from this type of shock. And we know that these types of shock have that common denominator where that reduction in tissue perfusion is going to impair cellular metabolism, putting the body in this, all the cells in the body in this anaerobic state. The next type of shock is anaphylactic shock, and we've talked about this in the context of allergies relating to type 1 hypersensitivities. This is an extreme and often life-threatening allergic reaction to an antigen to which the body has become hypersensitive. So some common causes of anaphylactic shock that I'm sure are not surprising to you are bee stings, peanuts, and penicillin in terms of allergies. Those with allergies have these mast cells that are sensitized with IgE. So they have IgE sitting on top of IgE receptors. This is called sensitization. So we could say sensitized mast cells. And so if you have this and you add in the antigen, so we have somebody who's, say, allergic to bee stings, they've become sensitized already to the bee stings, then they are stung again, and the antigen is present, or the allergen is present in their body, and it binds to the sensitized mast cells, it will lead to degranulation of all the mast cells in the body at the same time when it comes to anaphylactic shock. And so this will lead to one main event, which is the release of huge amounts of histamine all throughout the body. Continuing on with anaphylactic shock, just adding a few more important pieces of information. We know that when someone who's sensitized is exposed to the antigen, we'll have this many different mediators that are released. And this leads to a huge increase in capillary permeability and a subsequent loss of fluids because of the increased capillary permeability. So what's in the capillaries can leave much easier, and this will lead to edema. And peripheral vasodilation occurs, which will ultimately have an effect in reducing systemic vascular resistance. So the movement of blood throughout the vessels is reduced because of the reduction in resistance. And this can lead to an overall state of reduction in cardiac output, which then leads to those similar common denominators that we know occur with shock. The last point to make is that these mediators can also lead to constriction of the extravascular, so outside of the vessels, the smooth muscle. And that's why some people that have anaphylactic shock will end up with difficulty breathing because of bronchoconstriction and even laryngospasm. Now we'll move on to septic shock. And septic shock is a potentially fatal medical condition that occurs when sepsis, which is organ injury or damage in response to an infection, leads to dangerously low blood pressure and then abnormalities in cellular metabolism. But remember, caused by infection. So that's an important point. So again, septic shock starts with a microorganism or a pathogen. Bacteria is the most common, in particular gram-negative, and we'll talk about that in a minute. But the infection can affect the endothelium, which can lead to a systemic inflammatory response. Once that blood enters, or once the bacteria enters the blood, referred to as bacteremia, then it can affect all cells in the body. Now let's look at this a little bit closer on the right side of the screen. I know this looks like another very busy diagram, but only really a few key points, some which are will be familiar to you. I want you to remember that gram-negative bacteria mainly differ from gram-positive in that they have that wall-containing lipopolysaccharides, or LPS, which, when the bacteria is lysed or broken down, then the LPS can be released. And LPS are considered endotoxins. LPS can enter the bloodstream and it can travel to tissues where it will activate macrophages everywhere. And so here's showing you the lysed bacteria, the release of LPS, and the effect that LPS can have on macrophages, which is activating them everywhere. So many cytokines are released, affecting many organs in the body. You can see the various different cytokines, which you don't need to be aware of on this slide, but what I want you to understand is that the overall effect to different organs of the body can be, for example, at the level of the lungs, leading to adult respiratory distress syndrome, can lead to disseminated intravascular coagulation, or DIC. So remember, that's where there's coagulation that occurs throughout the body. So all of these clots can form, but then once the body runs out of clotting factors, because you're using more than you're producing, then these people will start to bleed. So they start with massive clotting everywhere, and then it leads to hemorrhaging. And so both adult respiratory distress syndrome and disseminated intravascular coagulation are related to the activation of the coagulation cascade pathway. Endothelial damage is almost always seen because of the release of these cytokines, and that was indicated initially when we first started talking about septic shock. And the endothelial cell damage can cause that systemic inflammatory response, but what it can lead to is multiple organ system failure as a component of that. And we'll look at this on an upcoming slide. Very, very dramatic event when this happens. This slide, not to be scared of it, because only a few main points that you need to be aware of, and this is really just another way of showing you what we discussed on the previous slide. When we have bacteria that ends up getting into the blood, so that's the pathogen that it causes the sepsis. It can either be a gram-negative organism or gram-positive. We spoke about gram-negative. It's because it's more commonly linked with septic shock because of LPS, as already mentioned to you. And then this ultimately leads to the activation of major systems that lead to what we discussed on the previous slide. So you don't need to know all the detail that's presented to you on this slide, but make sure that you understand some of the major difference between the different types of shock. Remember that on the previous slide I had mentioned that endothelial cell dysfunction can lead to multiple organ dysfunction, and that's what we're going to be talking about on the next couple of slides. So multiple organ dysfunction syndrome, or MODS for short. This is a potentially lethal syndrome that's caused, as you can see, by sepsis and septic shock, and it can lead to mortality when it is seen. So 50% die if 2 organs fail, 80% will die if 3 or more organs fail, and 100% will die if any of these failures stated last more than 4 days. And you don't need to worry about the actual numbers, but what I want you to be aware of is that 1, it's a very dramatic event. 2, the more organs that fail, the more likely the person will die. And oftentimes the organ failure that is evident is not what brought somebody into the hospital initially. So they're failing after the initial events of septic shock. Okay, this slide shows you the major pathophysiological events that occur in multiple organ dysfunction syndrome. Number 1, we have the multi-organ ischemia and necrosis is because there's been a decrease in tissue perfusion, and the longer the shock is left untreated, the more likely that further ischemia and necrosis will occur to multiple organs in the body. 2, multisystem acute inflammation. Ischemia will eventually result in inflammation throughout the body. 3, blood will be diverted to vital organs when shock happens at the expense of organs that are not considered vital. So that's that maldistribution of blood flow, which we know is common in the events of shock. Acute respiratory distress syndrome. I mentioned this, we talked about this during our respiratory topic, but it is a common event in MODS, as is acute renal failure, which we've discussed in our urinary unit, and disseminated intravascular coagulation, which we talked about in the hematologic unit, but we also mentioned that on a previous slide. And this can happen very, very quickly and simultaneously. Okay, on to our final topic, which is burns. Burns can be caused by physical or chemical damage to the skin. Of course, other areas such as the mucosa can be damaged within the body, but we're primarily looking at the skin in this lecture. The most common causes are related to heat, fire, electricity, radiation, acid or caustic agents. Caustic agents are agents that are able to burn by chemical action. Burns can be described in different ways. They can be described as the degree of the burn, so 1st, 2nd, or 3rd degree burns, which I'm sure you've heard of these terms before, and I'll give you a brief amount of information about each. 1st degree burns are a partial thickness injury involving the epidermis, so there is not injury then to the underlying dermis or the subcutaneous tissue. With this type of burn, the skin has maintained its water vapor and its bacterial barrier functions, which is very important. Many sunburns are 1st degree burns, so they're very common, very superficial, and tend to heal quite well. Blistering may occur up to 24 hours later, but do not appear initially with 1st degree burns. 2nd degree burns can either be a superficial partial thickness injury or a deep partial thickness injury. And the difference has to do with how much of the dermis is actually affected. So with a deep partial thickness 2nd degree burn, the entire dermis would be affected. Except that certain skin appendages such as the hair follicles and the sweat glands are usually not damaged. Now 3rd degree burns, they are also called full thickness burns or full thickness injuries, and this is destruction of the entire epidermis, the entire dermis, as well as the underlying subcutaneous tissue. And it can even be so extensive that it impacts the muscle or the bone beneath it. And with these third-degree full thickness burns, the skin function is absent. The tactile and pain receptors are also absent. I'd like to mention another comment here about the second-degree burns, and that is that blistering is very common quite quickly after these types of burns. And the reason for the blistering is because when the dermis, the part of the dermis is affected and vessels are damaged, then it can lead to the escaping of fluid that can form blisters. And of course, it's pretty obvious that the greater the degree of the burn, the greater the overall damage, with third degree being really having the worst outcome, where skin grafting is oftentimes needed, scarring will be likely, the area will not heal, and overall function and sensation will be gone. The extent of a burn can be estimated using what's called the rule of nines, and this would be applicable to somebody who was a burn victim, for example, and they need to estimate the approximate percentage of the body that was burned. The body is divided into 11 areas for a quick estimation, with each area representing about 9% of total body surface area, and the areas surrounding the genitals representing 1% of the body surface area. And so how this works when we say rule of nines, just to give you an idea, is that the head and neck, the anterior part, would be 4.5%, and then the posterior part would be 4.5%, totaling 9% for the head and neck. Another example here would be the torso. So we have the thorax and the abdomen totaling 18%. So this top part here would be 9%, this bottom part here would be 9%, and then the same posteriorly. And then with the arm, the anterior part representing 4.5%, the posterior representing 4.5%, totaling 9%. But with the legs, with them being longer and larger, 9% for the entire anterior leg and 9% for the entire posterior leg. So this, of course, would total 100%. And so if there's somebody who has suffered from burns to 50% of their body, it's because the burned areas are totaled up in terms of a percentage that's allotted to that area to determine that value. On this slide, you can see various images of different burns, and I will give you a bit of a description of each. This top one here is a superficial partial thickness burn, so that is the less intense second degree burn. You can see this is actually a scald injury, but there's overlying blistering, there's erythema present, it's very edematous. This next image is also a second degree burn, but it's a deep partial thickness wound. Remember, with that type of burn, the entire dermis is going to be affected. Moving on to the image beneath it, this is a full thickness burn, and this would be then a third degree burn where major damage would be evident. This image here is showing you the extensive amount of scarring that can occur, the necessity for skin grafting in certain areas after a burn. You can see in the axillary region here there's a contracture, and that can be common with third degree burns where overall mobility through that region would be reduced. The bottom here is showing you, even though we've spoken about the skin, the larynx, and I had mentioned that the mucosa can be burned. And this is much of an exaggerated response because the mucosa doesn't have the same form of protection that the skin has. So this larynx here can be burned by toxic fumes that are inhaled. So here's normal and here's burned. It's very inflamed and edematous, and it can obstruct the airways. And so in cases of those that are suspected to have this type of burn, intubation would be necessary. This slide shows the complications of a burn, and we'll look first at the systemic effects. Blood vessels are damaged, especially with second or third degree burns, as already mentioned. So intravascular fluid then will enter the interstitial space, leading to edema. Potassium can also escape from the cells. It can enter into the vessels, leading to hyperkalemia. Hypovolemic shock can occur, and this makes sense because of the amount of fluid that can be lost with burns. Remember that damage to muscles can lead to the release of myoglobin in the blood, which can end up at the level of the kidneys, and it's very toxic to the kidneys, so it can lead to acute renal failure because it's very toxic to the tubules. The body will, of course, be undergoing a generalized adaptation syndrome, a major stress response when a burn occurs. We've talked about that throughout this course, and susceptibility to infections. Well, it makes sense, number one, because the body has lost its first line of defense, which is that protective barrier of the skin, and now the body is exposed to potential pathogens. A little bit more about what we spoke about on the previous slide relating to hyperkalemia. Remember that cells have a lot of potassium inside, and when a cell is damaged, potassium can escape and it can enter the blood and lead to high levels of potassium in the blood. And this can affect such organs as the heart, which works on an electrical gradient. The brain can also be affected as well. So those that are suffering from hyperkalemia after a burn can end up with arrhythmias and can even have seizures because of this state. And this image is showing you the various fluid and electrolyte shifts that can occur as a result of a burn, but I verbally spoke in particular about the hyperkalemia. And on our final slide, this is showing you the major events that happen with an acute burn, really summarizing everything, and I'll just point out a few important components. Tissue injury, we know, will increase the permeability of capillaries, which will result in edema. This can lead to hypovolemia because of the loss of fluid from the vessels, which can lead to tissue ischemia, which can lead to multi-organ failure. That is the end of not only today's lecture, and not only at the end of Patho 2, but the end of your second year pathophysiology course. Thanks for everything, for being such great students, and I look forward to seeing you in the future.